Worldwide, each year, 1.4 million children are born with congenital heart defects, and over 350,000 children acquire heart disease. You are taking care of them. The vision of the World University for Pediatric and Congenital Heart Surgery is that every healthcare professional, anywhere in the world, involved in the care of patients with pediatric and congenital heart disease should have access to ongoing education. Education, communication, mentoring, knowledge everywhere and for all. Imagine being part of it.
Hello, I'm Dr. Ignacio Juaneda, and it is my great pleasure, along with my co-chairs, Dr. Abdelmalek Bouzid and Dr. Constantine D. Mavroudis, to welcome you to the World University for Pediatric and Congenital Heart Surgery 27th Educational Webinar. The subject for today is cerebral protection. During this 2.5-hour session, we are honored to have world expert international faculty members who will discuss important topics related to cerebral protection in congenital heart surgery. Please take a moment to note that there are no conflict disclosures for this webinar. Each presentation will be approximately 8 minutes and with 6 minutes reserved for questions from the audience. Please note that to maximize everyone's learning enjoyment of the educational material, the audience computer microphones will be muted. However, we encourage you to ask questions through your chat function on Zoom. To submit a question, open the chat function. Select everyone and type in your question and press the enter key on your keyboard. Also, please note that the program is recorded and will be available on the World University for Pediatric and Congenital Heart Surgery website within a couple of weeks. Okay, so let's get started with the program.
Thanks, Ignacio. So we will begin this 27th webinar with an introduction to historical perspectives by Richard Jonas from Washington, USA. Richard.
Good morning from Washington, D.C. I'm delighted to have this opportunity to talk about the historical perspective on cerebral protection during cardiac surgery. The first open heart operation was actually undertaken in 1952 and involved the use of hypothermic circulatory arrest with surface cooling based on experimental studies of hypothermia by Bigelow. The first open heart operation using the heart-lung machine was, of course, Dr. John Gibbon Jr.'s operation in Philadelphia in May 1953, 9 months later. By 1955, in Minnesota, Dr. John Kirkland, our president's father, was undertaking a large series of cases using the Mayo Gibbon IBM heart-lung machine, while at the University of Minnesota, while Lillehei was using the DeWalt bubble oxygenator to also undertake a large series of cases. But Lillehei had actually started in the previous year, 1954, a remarkable series of infant repairs using cross-circulation with the parent as an oxygenator. And this series was terminated because of brain damage that occurred in a parent who was the donor heart-lung machine. Already by 1954, reports had started to appear of the neuropsychiatric consequences of cardiac surgery, such as this report regarding psychological observations on patients undergoing mitral surgery. It really depended how hard you looked for cerebral complications as to what incidents you saw. For example, in this report in 1961, less than 2% of patients had persistent cerebral dysfunction. In this first prospective study undertaken by a neurologist who undertook preoperative and postoperative neurological examinations, you can see that nearly a third of patients developed important neurological complications, and these included serious problems, memory disorders, aphasia, alexia, agraphia, visual field defects, seizures, and hemiplegia. And based on autopsies, Gilman attributed these problems to hypoperfusion and embolism. So the evolution of cerebral protection during cardiac surgery in the early years focused very much on emboli and preventing hypoperfusion and hypoxia. And as time evolved, inflammation and edema became increasing targets. The improvements occurred in two basic areas: improvements in hardware and improvements in techniques. We all know that there are a large number of components of hardware in the heart-lung circuit, all of which are listed here. Early heart-lung machines were huge, and it was one size fits all. These enormous oxygenators from the 1950s were used for infants and toddlers and children, as well as adults, as were these disc oxygenators from the 1960s. All of these had very, very large priming volumes measured in liters. By the 1980s, when we were starting to do the arterial switch and Norwood operation at Boston Children's, there was at least a baby oxygenator, this bubble oxygenator, the baby Boz oxygenator. By the 1990s, we had a hollow fiber neonatal membrane oxygenator. And today, of course, oxygenators for newborns have very small priming volumes and have integrated arterial filters and heat exchangers. In the adult world, improved techniques for cardiopulmonary bypass have focused on minimizing calcific and atheromatous debris through improved cannula design and improved cannulation methods. Aortic clamping was found to be an important source of emboli, so clamp design and no clamp techniques evolved. Intracardiac air was a big problem in the early years, well before there was echocardiography or ultrasonography to detect air, and anticoagulation monitoring has also evolved and improved. In the neonatal world, the reduction in priming volume has been incredibly important by exposing babies to fewer blood products. There's been less intentional hemodilution, a better understanding of pH strategy, and also an improved understanding of circulatory arrest. Barrett Boys was really the first to popularize the concept of using circulatory arrest so that early primary repair could be undertaken to avoid the risks of an additional palliative procedure. And he recognized the deleterious effects of bypass and therefore minimized exposure to bypass by predominant surface cooling and surface rewarming. In Boston, Dr. Castaneda and Bill Norwood adopted the technique of hypothermic circulatory arrest as they also began doing early primary repairs, though they did not reduce the amount of surface cooling as much as Barrett Boys had. And meanwhile, in San Francisco, Paul Ebert, another very successful early primary repair advocate, emphasized very rapid cooling with cardiopulmonary bypass. So really by the mid-1980s, a perfect storm for the technique of circulatory arrest had developed with very rapid cooling, a very alkaline pH, severe hemodilution, and long periods of circulatory arrest. By the mid-1980s, in their landmark textbook, Dr. John Kirkland and Sir Brian Barrett Boys were beginning to write a lot about the damaging effects of circulatory arrest and hypothermia, as well as the inflammatory and other effects of cardiopulmonary bypass. They put together the work of a large number of investigators who were starting to look at the neurocognitive impact of circulatory arrest, people like Pat Clarkson working with Barrett Boys in New Zealand, Eva and Randy Greep in New York, Bill Baumgartner and Tim Cardner at Hopkins, myself and Jane Newberger in Boston, and Bill Gaynor also had a large team at CHOP. Fortunately, I had come to work closely with Dr. Kirkland helping with the second edition of their textbook, and he encouraged us to undertake a prospective randomized trial that came to be known as the Boston Circulatory Arrest Study, in which babies were randomized between circulatory arrest and continuous hypothermic bypass. The New England Journal report in 1993 did document a higher perioperative incidence of seizures with circulatory arrest relative to continuous bypass. But these children were followed for many years, in fact, continue to be followed. And by 8 years of age, there was no measurable difference between circulatory arrest and continuous bypass on any of the subtests or the overall results for general intelligence. In the adult world, Ken Taylor, Stan Newman, and Tom Treasure in London, John Hammond and David Stump at Wake Forest in North Carolina, and Mark Newman and Jerry Reeves at Duke also began publishing important studies like this one that came from the Duke group, where they pointed out that cognitive impairment was seen consistently in adults. And this was not subtle or minimal. This was at an equivalent level that if it was a footballer, they would be excluded from the team because of the level of cognitive impairment. Unfortunately, there really haven't been as many prospective studies of neurocognitive outcome after congenital heart surgery as would be ideal, although I should point out that in addition to the studies that came out of Boston, there have been studies like Rick Oye's study in which patients were randomized between regional cerebral perfusion and circulatory arrest. And that study did not document any significant difference between regional cerebral perfusion and hypothermic circulatory arrest. They concluded that a multi-center trial was needed. So in conclusion, the incidence of major neurological complications of cardiac surgery has been markedly decreased as the hardware and the techniques of cardiopulmonary bypass have been refined. And there really are many, many research opportunities remaining which can optimize neurodevelopmental outcomes for children with congenital heart disease. Thanks once again for the invitation, and I look forward to questions. Thank you.
Thank you very much for that, Dr. Jonas, that excellent historical review on the subject for today. As we're waiting for questions to fill the chat box, one that came to mind was what in your in your assessment, has been the single most important advance in either technique or technology that has advanced the field of neuroprotection most?
Well, I would say the reduction in the size of heart-lung machines, the elimination of with the reduction of the many deleterious effects, particularly the embolic consequences of being connected to a machine, a huge machine with no arterial filter. Remember that filters are quite complex in that it's easy to generate as many emboli downstream from a filter as upstream. So it took quite a few years to develop arterial filters to remove emboli. So refinement of the heart-lung machine, particularly the oxygenator, I would put as number one.
And I guess in a similar vein, what do you think is the most the greatest unmet need, or the question that requires the most dire answer in the ongoing debates concerning neuroprotection in our field?
Well, in the pediatric world, I think the the over-reliance on regional cerebral perfusion without a really good understanding of optimal methods for flow rate, temperature, and so on. I'm concerned that in place of circulatory arrest, the majority of centers are using techniques that are essentially homegrown and really haven't been proven to be safe in terms of optimizing neurodevelopmental outcome. So I think there are lots of opportunities in the regional cerebral perfusion world to optimize neurodevelopmental outcomes.
Excellent. And we have a question in the chat box, Dr. Becker. What do you think about the room for neurologic rehabilitation once all that is possible has been done during surgery?
Well, if there is, major neurological injury, then I think rehabilitation is extremely important. And fortunately, we have excellent rehab centers these days. But it's really pretty rare to have the sort of major neurological complications that were so common. I mean, it's a real eye-opener to read that 1965 article. This was Dr. Dwight Harkin at the Brigham and Women's, where I did some of my training. And if you read about the sorts of problems that patients were having in the 1960s, it's pretty remarkable. Those patients for sure need a lot of rehab. In the current world, where the majority of the problem is subtle cognitive changes, that is a little more tricky in terms of rehab.
And maybe just one final question from Dr. Zimpfer. The majority of research is more than 2 decades old, and there is rarely recent data. In your opinion, how much better would outcomes with optimized deep hypothermic circulatory arrest in 2023 be, with the important proviso that many centers, as you said, have kind of shifted to more homegrown methods?
Well, I mean, compared with the techniques of 20 or 30 years ago with rapid cooling and very alkaline pH and very dilute perfusate, I think there's no question that oxygen delivery is markedly better. I think in terms of comparing it to alternative techniques today, I do think that people need to think carefully, as a lot of patients are very small, at issues like caval injury, for example. If you feel like, oh, I have to do double cannulation, even though this is a 1.8 kilo baby with very fragile vessels, comparing a single cannula and cooling on circulatory rest with the sorts of techniques that involve multiple injuries to vessels through cannulations, I strongly suspect that the technique of circulatory rest would be proven to be markedly preferable to techniques that injure a lot of vessels in very small fragile premature babies. But and as I say, this is exactly where there are lots of opportunities for well-conducted prospective trials.
Okay, we go to the second presentation from Jennifer Lynch, Philadelphia, USA, about cerebral protection challenges associated with neonatal and pediatric neuroprotection. Jennifer.
Hi, my name is Jennifer Lynch, and I'm an anesthesiologist at the Children's Hospital of Philadelphia. Thank you to the organizers for the invitation to give a talk today on the challenges associated with neonatal and pediatric neuroprotection. I have no financial disclosures. The motivation behind the session today is the high prevalence of neurodevelopmental disability that occurs in school-age survivors of neonatal cardiac surgery. We observe a multitude of neurologic symptoms in this patient population, including decreased executive function, behavioral disorders, and decreased cognition. In fact, when we ask parents of school-age children with congenital heart disease what their current main concerns are, they often describe being most concerned with these neurobehavioral symptoms. This highlights the fact that although we have made tremendous strides in the surgical and medical care of these patients over the last several decades, we are still falling short of significantly improving the neurologic outcomes. This is why the session on neuroprotective strategies is so important. As we improve the cardiac care of these patients, the risk of neurodevelopmental disability is becoming the most common and potentially most disabling complication of congenital heart disease. So what are we doing about this? Well, if you ask the anesthesiologists, intensivists, and surgeons who take care of these children on a day-to-day basis, they will likely name some or all of the items on this list. As you can see, these are neuroprotective strategies that are mostly focused on the operative period of neonatal cardiac surgery. We will be hearing about some of these strategies in more detail later in this session. But basically, there has been limited evidence on the efficacy of these strategies to improve either neurologic outcome or decrease the incidence of brain injury on MRI following neonatal cardiac surgery, with the exception of avoiding extreme hemodilution. Furthermore, despite many of these strategies becoming standard of care at some institutions, we have not seen a remarkable improvement in neurologic outcomes. This failure to significantly improve neurodevelopmental outcomes was demonstrated in this study published by the Cardiac Collaborative on Neurodevelopment Investigators on pooled data from over 1,700 subjects. Neurodevelopment evaluations were performed at approximately 15 months of age using the Bailey scales of infant development and quantified using a psychomotor developmental index and a mental developmental index. For this cohort, both of these indices were lower than normative means. This figure shows these scores for psychomotor and mental development over the years of the study, from 1996 to 2009. As you can see, later calendar year of birth is associated with improved development index for both PDI and MDI. However, later year of birth is also associated with an increased proportion of high-risk infants that are being cared for. After adjusting for center and type of CHD to account for this, later year of birth was no longer associated with better neurodevelopment. Interestingly, though, the association does exist after adjusting for innate patient risk factors such as birth weight, genetic anomaly, and gender. The importance of innate patient factors on these developmental indices brings insight into why we have not made greater strides in improving neurodevelopmental outcomes in this patient population. The majority of our neuroprotective strategies target ways we can protect the brain during cardiac surgery. But research over the last decade has started to show us that risk factors during the operative period are likely not the greatest contributors to the neurodevelopmental outcomes that we are seeing later in life. This point was highlighted in the 16-year follow-up to the Boston circulatory arrest trial. This landmark study randomized infants with transposition of the great arteries undergoing the arterial switch operation using deep hypothermia with either total circulatory arrest or continuous low flow bypass as the predominant method of vital organ support. Early phase of this study showed that increased rates of perioperative neurologic morbidity were associated with the group that was assigned to DHCA. However, when they followed up with these children 16 years later, the assignment to the DHCA group was only associated with worse visual spatial function. Instead, what they found to be the most predictive of neurodevelopmental outcomes was family social class. They stated in this text that the family social class, along with factors like genetic anomalies and fetal circulation, likely contribute as much or more than medical and surgical strategies. Studies have specifically looked into the effect of fetal circulation on neurologic outcomes in these patients. Fetal brain imaging studies have shown us that the brains of infants with congenital heart disease differ from healthy controls even prenatally. The studies shown here measure total brain volume in fetuses with congenital heart disease and in control fetuses. Until 26 weeks gestational age, total brain volume does not differ significantly between these two groups. However, during the third trimester, fetuses with congenital heart disease have a decreased growth in total brain volume. And this is particularly impaired in fetuses with heart defects that result in abnormalities in aortic outflow. We have also seen evidence that this lower fetal brain volume correlates with worse neurodevelopmental outcomes later in life. This table shows that the fetal brain volume is statistically significantly related to two-year Bayley scale scores. In addition to total brain volume, studies have looked at brain maturation. This work from the Children's Hospital of Philadelphia looked at 42 neonates with either hypoplastic left heart syndrome or transposition of the great arteries. This study found that the brain maturation of a full-term neonate with critical congenital heart disease is similar to that of a 35-week premature infant without congenital heart disease. This similarity between the brains of full-term neonates with critical congenital heart disease and premature infants without congenital heart disease leads us to this idea of encephalopathy of congenital heart disease. Bill Gaynor has used this terminology to mirror the encephalopathy of prematurity that has been previously described. Similar to premature infants, in infants with congenital heart disease, there exists a complex interrelationship of innate and environmental risk factors that leads to the wide distribution of neurocognitive impairment in this patient population. The studies I have mentioned here, along with others, are contributing to a growing body of evidence that abnormal brain development begins in utero, and this leads to brain immaturity at birth, which increases vulnerability to hypoxic ischemic white matter brain injury. Intervening at the time of surgery, although potentially important to avoid further injury, is likely not early enough to significantly improve neurodevelopmental outcomes in this patient population. This recent study from the Children's Hospital of Philadelphia demonstrates this. In this study, 183 neonates with critical congenital heart disease were studied and underwent a brain MRI on the morning of surgery prior to any surgical intervention. They found that 20% of these neonates already had some brain injury prior to surgery. And the risk factors for this injury were gender, brain maturation, how long the baby had waited from birth until surgery, and impaired maternal fetal environment, which included things like gestational hypertension, gestational diabetes, and hypothyroidism. Again, these results highlight the fact that prenatal factors are contributing to vulnerability to injury, and an injury is already present prior to any surgical intervention. The fact that age at MRI was associated with increased risk of brain injury points to one potential postnatal modifiable risk factor, and that's the timing of surgery. Time to surgery, or how many days these neonates wait from birth until surgery, has been shown to predict white matter brain injury in previous studies. Shown here are the results from two studies, both performed at the Children's Hospital of Philadelphia in infants with hypoplastic left heart syndrome, which is the study shown on the left, and transposition of the great artery, which is the study shown on the right. In both of these studies, there was an increased risk of white matter brain injury on MRI with longer time between birth and surgery. Avoiding long time to surgery may be one neuroprotective strategy that can be utilized during the preoperative time period. I'm going to conclude my talk by showing this diagram. Again, the majority of the neuroprotective strategies that are currently utilized focus only on the center of this diagram, which shows the neonatal cardiac surgery. However, patient and environmental factors such as prematurity, genetic syndromes, and socioeconomic status are likely more important determinants of neurodevelopmental outcomes than operative management strategies. Additionally, there is a growing body of evidence that brain abnormalities develop in utero and lead to increased vulnerability. Shifting our focus to the preoperative period may help decrease the incidence of brain injury, but to significantly improve neurodevelopmental outcomes, neuroprotective strategies likely need to be initiated prior to birth. Thank you.
Excellent talk, Dr. Lynch, on a subject that has certainly changed the way that a lot of us view neuroprotection in this field. As we're waiting for some questions to populate the chat box, one thing that came up to me was, it does seem like it's not just a coincidence that the transition from fetal to antenatal life occurs over the course of a few days in these critically ill neonates. And the question is whether you think there's any kind of connection between that process, particularly in infants with either incompletely developed autoregulation or cerebrovasculature, that makes them more at risk for primary and secondary brain injury as they wait for surgery. That is to say, a connection between the time to surgery and this transition with a sort of immature cerebral vasculature from fetal to antenatal life. If you have any thoughts on that.
Yes, thanks for that question. So we have done a study at CHOP looking at cerebral hemodynamics in these babies from when they're born as they're waiting for their surgery. And we noticed that their cerebral saturations continue to decrease, which is something that you don't see in healthy neonates. You do see an increased oxygen extraction in healthy neonates when they're born as they're transitioning to postnatal life. But in healthy neonates, you see an increase in cerebral blood flow to accommodate for this increase in oxygen demand. But in infants with congenital heart disease, we're not noticing that increase in cerebral blood flow. So one hypothesis is that the decrease in cerebral vascular resistance that exists in these patients in utero, which has been shown in fetal imaging studies, may then lead to an inability to decrease their cerebral vascular resistance even more to accommodate for increase in oxygen demand in postnatal life. We're currently doing a study immediately after birth in that transitional period for the first hour to see if there's any way of intervening postnatally to help with this.
Fascinating. And just as a follow-up, because that's a very thought-provoking line of inquiry. What, if any, kinds of potential interventions would such a study target?
So one of two things, either decreasing oxygen demand or increasing oxygen delivery, or like we showed in that previous plot I just showed, or going to surgery earlier if there's nothing else you can intervene. But we do know that they are able to increase the cerebral blood flow for some perturbations. We did a study where we delivered increased CO2, and they are able to vasodilate and increase blood flow due to that perturbation. But for some reason, due to innate needs to increase blood flow, such as increased oxygen demand, they don't seem to be able to do that. So that we are looking into sort of this neurovascular coupling about why that might be. But one of those two things that you would want to target to try to avoid this problem of increasing risk of hypoxic ischemic injury.
We have a question in the chat box from Dr. Bouzid. Is there a surgical strategy or potentially a medical intervention that could take place in the intrauterine period to prevent such a troublesome neurological impact of the transition to antenatal life or early surgery?
Probably a better question for my fetal surgical colleagues, but we do know that infants with aortic outflow obstruction have the lowest decrease in cerebral vascular resistance in utero. So those would be the patients that we would potentially want to intervene on. But I'm not going to try to speak to fetal surgical strategies that we could potentially do.
Excellent. Well, I think we have one more question. What would be the interaction or effects of anesthesia in relation to neurodevelopmental outcomes and the relationship of deep hypothermic circulatory arrest versus regional cerebral perfusion?
So I'll answer the second question first. Like Dr. Jonas mentioned, there have been studies that have looked at DHCA versus RCP and have not shown a significant improvement with RCP. But also, like Dr. Jonas said, we aren't doing RCP in the most intelligent way currently. So studies are currently ongoing about ways we can target our RCP flow rate to specifically meet the needs of that patient to potentially improve the outcomes of RCP over DHCA. And we also know that the timing of DHCA matters. So potentially a short period of DHCA may have a lower risk profile than RCP, whereas a longer time period of DHCA may that the opposite would be true. And then the first question about the effects of anesthesia, a lot of research has been done in non-congenital heart populations about the effects of anesthesia on developing brains in neonates, and there hasn't been conclusive evidence of any problems with more anesthetic exposures. But a lot of issues with this research is that children who need multiple anesthetic exposures are already sicker to begin with, and that's going to be the same case with congenital heart surgery. So it'll be a hard problem to really figure out. But obviously they're going to need anesthesia to undergo the surgery. So the question is what anesthetic, and that's something that research is ongoing.
Well, thank you again, Dr. Lynch, for an outstanding talk. And with that, we will move on.
Okay. Third presentation on deep hypothermic circulatory arrest, background principles, adverse effects will be presented by Daniel Zimpfer from Graz, Austria. Dr. Zimpfer.
Dear Chairman, ladies and gentlemen, I would like to thank for the invitation to present and congratulate the organizers on really putting together an outstanding webinar. The topic of my presentation is deep hypothermic circulatory arrest, which certainly is one of the mainstays of pediatric cardiac surgery and responsible for a lot of the advantages that we made, especially in early years. Since the introduction of deep hypothermic circulatory arrest, and Professor Jonas already outlined the history in an outstanding manner, significant progress has been made. And different additional perfusion strategies that support neuroprotection and also organ protection during deep hypothermic circulatory arrest have been developed. My talk will primarily focus on the conduct optimization outcomes of deep hypothermic circulatory arrest, and I will not cover additional perfusion techniques as they will be addressed by subsequent talks. The principle of deep hypothermic circulatory arrest is to prevent ischemic injury to organs and allow for cessation of circulation or cardiopulmonary bypass. This has distinct advantages that include and improve because bloodless visualization of the surgical area, reduced exposure to cardiopulmonary bypass, avoidance of unnecessary cannulas, and potentially reduction of postoperative edema. The real mechanism behind deep hypothermic circulatory arrest is that by lowering the body temperature, we can decrease the metabolism in the brain, and we can decrease that to up to 12% of normal thermic levels at 18 degrees of body core temperature. This then has different mechanisms of actions that, first of all, target the entire cellular metabolism, but also influence the accumulation of excitatory neurotransmitters, which are further drivers of neurologic injury. What are the typical indications for deep hypothermic circulatory arrest? If we look at the entire spectrum of cardiac surgery, this of course includes aortic artery construction, complex congenital heart defects, pulmonary thromboendarterectomy, surgery of the thoracoabdominal aorta, repair of cerebral aneurysms, resection of AV malformations, and some not very frequent, but still done indications as resection of large renal cell carcinomas with caval invasion, or resection of other tumors with caval invasion. In the distinct field of pediatric cardiac surgery, typical indications include interrupted aortic arch, stage 1 repair in hypoplastic left heart syndrome, obstructed TAPVD, redo TAPVD, different redo situations with intracardiac shunts that can result in catastrophic air embolism should the heart be injured at the time of sternal re-entry, transposition of the great arteries, and very low birth weight newborns. The conduct of deep hypothermic circulatory arrest is standardized to a certain fashion. Most centers will use standard CPP cannulation. Cooling to different blood temperatures should be performed with temperature gradient exceeding not more than 10 degrees Celsius, and cooling should be performed for at least 30 minutes. During deep hypothermic circulatory arrest, topical head cooling can be used as an adjunctive measure to eliminate passive rewarming. I will discuss different management strategies of CPP during cooling later during the presentation. There are certain concomitant medications that are used by some centers. These include barbiturates for reduction of cerebral metabolism, mannitol to help reduce potential increased intracranial pressure and reduce free radicals, steroids to promote cell membrane integrity and reduce brain swelling. The period of deep hypothermic circulatory arrest as a general principle should be kept as short as possible and necessary, and rewarming should be performed during what I usually consider to be the rest of the procedure. So parts of the procedure where DHH is not necessary. Rewarming itself should take at least twice as long as cooling, and blood temperature should not overshoot, so it should not exceed 37 degrees. There are different definitions and also probably levels of deep hypothermic circulatory arrest. And depending on the nasopharyngeal temperature that is achieved during cooling, groups will differentiate between profound, deep, moderate, mild hypothermia. This is a typical screenshot and basically outlines what happens during the period of deep hypothermic circulatory arrest. As you can see on the left side, the patient has been cooled to a core temperature of 14 degrees Celsius. Circulation is stopped. ECG shows no cardiac activity, and blood pressure is basically zero. And immediately, and this can be seen on the right screen, in parallel to the induction of deep hypothermic circulatory arrest, also inverse saturation will start to drop and come down. How long is it safe? This is subject to ongoing discussion. We are all aware that very short times of cerebral ischemia can be tolerated at normothermia at 27 degrees. General consideration will be that 15 minutes of cerebral ischemia can be tolerated at 17 degrees 41 minutes. In small pediatric patients and newborns, the safe period of circulatory arrest can certainly be longer, but in general, there is no clear cutoff, and injury probably accumulates over time. I would like to discuss some management strategies during cooling and also during conduct of deep hypothermic circulatory arrest. These include acid-base management, hematocrit, low flow versus complete deep hypothermic circulatory arrest, and the influence of postoperative hyperthermia. There are two basic principles for pH management during cooling, alpha stat and pH stat, and these strategies have been analyzed in multiple studies. So if we go back to physiology and also to the basics of acid-base management, if we use the alpha stat method, the blood gas machine basically measures carbon dioxide partial pressures and oxygen partial pressures at normothermia. If we use the pH step method. This involves adjustment of the pH to the patient's blood based on their actual body temperature during deep hypothermic circulatory arrest. There are distinct differences between the two methods, and if we look basically and primarily at experimental data, what becomes obvious is that cerebral oxygenation and brain tissue oxygen saturation is better in pH stat than in alpha stat during profound hypothermia. pH stat also provides more oxygen delivery to the brain tissue before deep hypothermic circulatory arrest. The influence of this on clinical outcomes has been studied by the Boston group in a large prospective randomized trial, and they compared 182 patients that underwent surgery in deep hypothermic circulatory arrest with alpha stat versus pH stat. And what they found is that was that alpha stat was associated with a higher incidence of adverse events, including death, a trend towards higher cardiac index with pH stat, and lower inotropic support with pH stat. This also translated to a trend towards higher mental development index scores in the pH stat subgroup that, however, was not significantly different. The next management strategy I'd like to discuss is the optimal hematocrit threshold during CPB and during deep hypothermic circulatory bypass. These are experimental data on different hematocrit levels during cardiopulmonary bypass in animal experiments that were designed to delineate the optimal hematocrit during deep hypothermic circulatory arrest. The conclusions and results of this study is that higher hematocrit does not impair cerebral microcirculation and reduces white cell endothelial activation of the deep hypothermic circulatory bypass and circulatory arrest. Severe hemodilation, on the other hand, results in evidence of inadequate cerebral tissue oxygenation during cooling phase of CPB, and these experimental data have suggested that a hematocrit of 30 is preferable relative to a lower hematocrit. As a consequence of these experimental data, the effect of hematocrit during hypothermic cardiopulmonary bypass in infant heart surgery was studied in the combined Boston hematocrit trials. And again, this study, and this supports the experimental data, revealed that the hematocrit level at the onset of cardiopulmonary bypass of approximately 24% or higher is associated with improved psychomotor development index scores and also reduced lactate levels. So these two studies underline that a higher hematocrit is preferential in the setting of deep hypothermic circulatory arrest or perfusion at hypothermia. And another very important trial is this study that was also conducted in order to elucidate and study whether low flow CPB or deep hypothermic circulatory arrest results in improved clinical outcomes. And the result of this trial was that deep hypothermic circulatory arrest is associated with greater CNS preturbation in the early postoperative period than the strategy of predominantly low flow CPBs of note. Neither of these groups were sole circulatory arrest or low flow perfusion groups, but certainly this trial shows the potential adverse effects of prolonged periods of low flow of deep hypothermic circulatory arrest in comparison to low flow CPB. And this also becomes obvious when the outcomes in relation to the duration of deep hypothermic circulatory arrest versus low flow CPB are analyzed, with a significant correlation of circulatory arrest times and psychomotor developmental disorders, as well as neurological problems. If the same patients are evaluated 8 years after surgery, and this really probably is what delineates the clinical significance of this trial, the conclusion is that the use of total circulatory arrest to support vital organs during heart surgery in infancy is generally associated with greater functional deficits than low-flow cardiopulmonary bypass. Of note, both groups that underwent surgery in the neonatal period are associated with increased risk of neurodevelopmental vulnerabilities. The last and a very important finding, and this relates to the importance of postoperative hypothermia, so an overshoot of temperature at the end of rewarming, is this study again from the Boston group that looked into the post-ischemic, into the effects of post-ischemic hypothermia after deep hypothermic circulatory arrest. And what this study showed was that post-ischemic hypothermia really exacerbates neurologic injury and is certainly something that has to be avoided at any cost. So in summary, the current advantages, or what are the advantages of a deep hypothermic circulatory arrest in 2023? It certainly is a bloodless visualization of the surgical area with no cannulas that distort anatomy. The main disadvantages are risk of permanent neurologic injury, which is time-dependent, with no definite safe time, an excessive risk of bleeding due to coagulopathy. How do we perform it right? We have to be patient during cooling and rewarming. The hematocrit should be above 24%. pH stat strategy is superior to alpha stat. Intermittent flow periods certainly are beneficial. Postoperative hypothermia or hypothermia after rewarming has to be avoided at any costs. And when do we at our department still use it? We still use it for intracardiac repairs in premature neonates below 2.5 kilograms of body weight. In all cases with a neonatal repair of total anomalous pulmonary vein connection, in complex redos to avoid air embolism in case of inadvertent injury to the heart. And we switched to a strategy of integral cerebral perfusion for all arch reconstruction, including Norbert stage 1 surgeries. Thank you very much.
Outstanding talk, excellent review. Unfortunately, we probably don't have time for questions, but I would encourage people to use the chat box feature to converse with Dr. Zimpfer directly. But with that, let us move on to our next talk.
Okay, the next talk will be neuroprotective cerebral perfusion strategies without deep hypothermic circulatory arrest, presented by Yusuke Ando from Fukuoka, Japan. Mr. Ando.
It is
Good morning.
great honor
Hello.
to talk on this theme today. Before I start, I'd like to thank the World University for Pediatric and Congenital Heart Surgery for inviting me to speak today. There is no COI. Today I'd like to talk about our total body perfusion technique for neonatal arch reconstruction. When deep hypothermic circulatory arrest, the DACA, is used in neonatal cardiac surgery, many organs and systems are in danger. DACA can cause brain damage, renal insufficiency, coagulation disorder, and endothelial dysfunction. The point here is that the brain has the shortest safe circulatory arrest time of any organ. I want you to look at these two figures, which show that the longer the DACA time, the greater the probability of brain damage. Because cerebral metabolism is maintained even at low temperatures, the brain is exposed to ischemic injury even during DACA. In other words, there is no absolute safe duration for DACA. To avoid DACA, we have devised perfusion techniques. In the early 80s, cannulation of descending aorta began so as to shorten circulatory arrest time. In 1994, selective cerebral perfusion, a technique to maintain cerebral perfusion through a cannula inserted into the innominate artery, was introduced. In 1998, the total body perfusion technique, which combines lower body perfusion and selective cerebral perfusion, was established. This technique allowed us to completely avoid circulatory arrest during the Norwood procedure. This slide shows the anatomy around the descending aorta. The descending aorta is located left posterior to the esophagus. So when approaching the descending aorta through median sternotomy, one should enter the left thoracic cavity, compress the esophagus to the right, and look for its dorsal side. Here I show you our pump circuit. The pump consists of a single pump and a double arterial line. Pump flow rate is maintained at 170 milliliter per kilogram per minute, and the rectal temperature are lowered to 30 degrees. In the early era, we used to sew EPTFE grafts to the innominate artery as a perfusion line. Recently, we prefer to cannulate the innominate artery. The most frequently used cannula size is 2.0 millimeter. Now I'd like to show you a video of our total body perfusion technique. After dissecting neck vessels, a purse string suture is placed to the innominate artery. Then a small incision is made in the posterior pericardium just left to the inferior vena cava. The descending aorta can be easily found posterior to the esophagus. Localized dissection is done to expose descending aorta clearly, and a purse-string suture is placed to it. Another purse-string suture is placed to the inferior vena cava, and the pump circuit is trimmed to an appropriate length. A 2 mm cannula is inserted into the innominate artery. One must be very careful because the vascular wall of innominate artery is very thin. Then we prepare for the descending aortic cannulation. We use this custom-made cannula holder. A 2 mm cannula is inserted into the descending aorta with the cannula tip pointing towards the foot. After inferior vena cava cannulation, the pump is started. A flow meter is placed to measure the perfusion balance between upper and lower body. Now, what are the pitfalls of this technique? Because the brain is perfused only through the innominate artery, the integrity of circle of Willis is essential. It is known that abnormalities of the circle of Willis are found in 5% of the population. This is a representative CT scan of a patient with incomplete circle of Willis. In this patient, preoperative transcranial Doppler showed symmetric flow pattern. But when the carotid artery was clumped, the flow of the left middle cerebral artery was lost. By declumping the carotid artery, the flow had restored. So, we decided to insert a small cannula into the left carotid artery to perfuse the left hemisphere. Then, what are the recommended techniques for cerebral monitoring? Near-infrared spectroscopy is a technology for estimating oxyhemoglobin saturation in tissues. It is a simple, non-invasive, and continuous method to assess the neurologic status. Here we have some data from our patients. On the left is Norwood operation with total body perfusion, and on the right is corrective neonatal surgery with standard CPB. You can see that with total body perfusion, cerebral and renal oxygen saturation are maintained high during artery construction, similar to patients undergoing standard CPB. This slide shows the protective effect of descending aortic cannulation on post-operative renal function. Patients undergoing descending aortic cannulation had lower creatinine levels and lower risk of rifle injury or failure. I'd like to finish by making the following points. Firstly, the total body perfusion technique can completely avoid DHCA during neonatal arch reconstruction. Secondly, this technique may help protect the brain from ischemic injury. Finally, multimodal monitoring is important when conducting this technique. That's all I have to say. Thank you for your attention.
Outstanding talk. A lot of very innovative strategies there. As expected, there's some questions brewing in the chat box. One of them is, how do you modulate the flow in each of the arterial lines? You mentioned that there was a flow probe placed on the descending aorta line, but are there additional ways that you either troubleshoot this or standardize your approach to ensure optimal perfusion to each vascular bed?
Mm-hmm. Thank you for your question. First, I apologize that the video didn't work so smoothly. And the question is how to control the flow between the lower and upper bodies. And actually, our target is to maintain the flow, equal flow to the lower and the upper body. And by using the same cannula size, usually the flow is 1-to-1, is usually equal. So usually we don't need to do anything to control the flow.
And when you're doing, just to add to that, when you're doing bilateral carotid perfusion, do you also rely on the difference in cannula size, or do you run it through a separate pump? Like some groups will purge the plegia line and use that. How do you set up for bilateral carotid perfusion?
In that case, we just put a very small cannula into the left carotid artery from the branch of the upper body arterial line. We just wanted to perfuse a small amount of blood into the left, so just a small cannula and a perfuse from the branch line was enough, we thought.
Okay, no, excellent. Dr. Juaneda commented, can you comment on the types and the complications with this strategy, that is to say total body perfusion versus regional cerebral perfusion on arch and norwood patients specifically? So has your group compared their outcomes with other centers that employ different techniques?
You mean I compare the results of the different strategies?
Correct.
No, actually, we are using this technique for all the arch repair patients, so we don't have enough data to compare the results by any other techniques.
Okay. Sort of piggybacking on that, how did your group decide on the temperature at which to perfuse in total body perfusion?
We had our policy is to do the full flow in a normal or mild temperature. So we try to use the full flow bypass with normal or only mild hypothermia.
And to those who might say that you would have additional organ protection if you were to perfuse cooler, what would you think about that?
If is there any like some I want to say that hyperperfusion of the head or too much perfusion pressure, we will decrease the temperature gradually and decrease the flow in that case.
Excellent. And I guess just quickly before we move on, this has been an excellent discussion. How many arterial lines do you have in these patients? I would think at least 2.
Just one arterial line in the right radial artery.
Excellent. Okay. All right. Well, unfortunately, we do have to move on. I'm sure I could pepper you with questions all day about this very interesting technique that you guys are employing, and I certainly congratulate you for this. But with that, we'll move to our next speaker.
Thank you very much.
So we move to the next presentation, Pharmacological Neuroprotective Agents, Use and Efficacy, presented by Dean Andropoulos from Houston, USA. Dean?
Greetings. I'm Dean Andropoulos, anesthesiologist in chief at Texas Children's Hospital in Houston, and I'll be speaking about pharmacological protective agents, use and efficacy. My disclosures are for research funding for the trials I will describe and discussion of off-label use of the neuroprotective drugs I will be speaking about. The learning objectives are to understand research data and potential clinical use and efficacy for cerebral protection in congenital heart surgery for allopurinol, erythropoietin, dexmedetomidine, and inhaled nitric oxide. First, allopurinol, as you know, is a xanthine oxidase inhibitor, US FDA approved for the treatment of gout, prevention of tumor lysis syndrome, prevention of recurrent calcium nephrolithiasis in patients with hyperuricosuriya, and the IV form is approved in pediatric patients for prevention of tumor lysis syndrome. This trial, published way back in 2001 with Dr. Gaynor as one of the investigators, assessed neurocardiac protection in infants undergoing heart surgery using deep hypothermic circulatory arrest. Allopurinol inhibits xanthine oxidase conversion of oxygen to oxygen-free radicals in oxygenation and reperfusion. Additional mechanisms of neuroprotection include reduction of reactive nitrogen species, preservation of cerebral energy metabolism, pro-radical chelator of non-protein bound iron, and also anti-inflammatory properties. So this was a single center, randomized, placebo-controlled, blinded trial of 350 infants less than 45 weeks conceptual age, all with circulatory arrest. Hypoplastic left heart syndrome was compared to all other lesions listed there. Allopurinol was administered in 3 preoperative doses, 1 dose to the bypass prime, and 9 postoperative doses for 72 hours, and the primary efficacy endpoint was a composite of seizures, coma, or cardiac event. The main results are shown here, with the primary event of seizure, coma, or cardiac event was significantly less in the hypoplastic left heart syndrome patients, and the proportion of event-free patients also was much higher. For the non-HLHS patients in the group as a whole, there was no difference. And so the conclusion of this study, allopurinol decreased the incidence of seizures, coma, and cardiac events in HLHS, but not other lesions. Fast forward to 2022, and this is a description of the trial protocol for the Crucial study from the Netherlands. This is a phase 3 randomized, quadruple-blinded, placebo-controlled, multi-center trial of neonatal cardiac surgery with bypass, with a primary outcome being a 20% reduction in moderate to severe ischemic or hemorrhagic brain injury on MRI being too unstable for postoperative MRI or death, and 236 subjects are required for 80% power with a two-sided alpha of 5% to demonstrate the primary outcome with about a 5-year study duration. It's a very interesting trial protocol that, in my opinion, is an example for all pharmacologic neuroprotection studies. So this study in patients with an in utero diagnosis actually starts with allopurinol administered within 45 minutes after birth, another pre-op dose 12 hours afterwards, another pre-op dose 12 hours before surgery, a dose at the start of bypass and for 24 hours after surgery. Patients without a diagnosis in utero still receive the preoperative allopurinol medication. This is the table of studies. Again, I think this is a model. There are MRI outcomes 4 to 7 days after birth. There are a number of other clinical neurological assessments, including at 3 months, and then a comprehensive Bayley 3 scale assessment at 24 months. There is an echocardiography, and there are laboratory studies of redox and antioxidant status and pharmacokinetics, and of course, safety events. So this is a very important study that I will be watching carefully for results. Erythropoietin is a 30.4 kilodalton glycoprotein produced mainly by the peritubular cells in the renal cortex in direct response to hypoxia, in response to hypoxia-inducible factor 1 production, and indirectly to anemia. Small amounts of EPO are also produced in spleen, liver, bone marrow, lung, and brain. And the liver, though, is the primary site of EPO production in the fetus. EPO increases red blood cells and has anti-apoptotic, anti-inflammatory, and anti-excitatory effects, protecting cells against death in a variety of conditions. It's been utilized for decades in premature infants to prevent or treat anemia and has been the subject of 11 randomized controlled trials for neonatal hypoxic ischemic encephalopathy treatment. We published this study 10 years ago, hard to believe, but this was neonates undergoing surgery with bypass for hypoplastic left heart syndrome, transposition, VSD and arch interruption, truncus, and TAPVR, a prospective randomized placebo-controlled blinded trial of EPO, 1,000 units per kilogram IV in 3 doses, 12 to 24 hours pre-op, immediately after bypass, and 24 hours after dose 2 versus placebo. This was in the first 33 subjects. The FDA mandated a dose reduction to 500 units per kilogram after adverse events in adult clinical trials. This was the last 26 subjects. A brain MRI was done preoperatively and 7 to 10 days postoperatively, and Bayley Scales of Infant Development 3 was performed at 12 months. The MRI findings are summarized here. The bottom line is there's no difference whatsoever in any MRI parameter of brain injury or of venous sinus thrombosis or any other adverse MRI findings. And also the 12-month Bayley scales of infant and toddler development were no different in the 42 patients who underwent this examination for erythropoietin versus placebo. So the conclusion of this study, EPO is safe. There were no real adverse events. The dosing results in sufficient plasma levels for neuroprotection, we think, and there's no difference in MRI or neurodevelopmental outcomes in this small pilot study. However, this study in New England Journal, published just last year, was erythropoietin neuroprotection for hypoxic ischemic encephalopathy in newborns. And this was a very well-designed multi-center trial. And in HIE with hypothermia, which is now standard treatment, erythropoietin made no difference whatsoever in any of the outcome measures, which included death or any neurodevelopmental impairment. It included low Bayley 3 cognitive scores at age 24 months, cerebral palsy, or significant motor impairment, no difference. Encephalopathy, no difference, and no difference with gender. However, adverse events were higher in the erythropoietin group. So the conclusion of this study, EPO did not decrease death or neurodevelopmental impairment in neonatal HIE, but increased adverse events. Despite this, as late as 2021, this very nicely done review article asks the question, can erythropoietin reduce hypoxic neurological damage in neonates with congenital heart disease? Very nicely reviews the mechanisms and advocates for a trial. I don't think that this will likely happen. I don't think it would be funded in the US because of the results in the neonatal HIE studies. Dexmedetomidine, as you know, is a novel sedative hypnotic analgesic agent, has very desirable properties in humans, minimal respiratory depression, reduces post-cardiac surgical tachydysrhythmias, reduces doses of volatile agents, opioids, and benzodiazepines. And in animal studies, there is no neuroapoptosis in the developing brain. It will block neuroapoptosis by anesthetic agents. It's neuroprotective in hypoxia, ischemia, and in inflammatory states. So we were able to complete this phase 1 safety and pharmacokinetic study in infant cardiac surgery out to age 6 months for 2 ventricle repairs. This is 122 subjects. There were only 5 minor to moderate rhythm problems, junctional rhythm, 2nd and 3rd degree heart block, which was easily treated and resolved fairly quickly. So the safety of this agent was very good. And we also devised a very comprehensive pharmacokinetic model that led to this dosing scheme, enabling the practitioners to choose a target plasma concentration at the higher concentrations of 700 to 1,000 picograms per ml. It is postulated that there would be neuroprotection at those plasma levels. So this study demonstrated that DEX is safe. The PK model resulted in dosing to achieve a high steady-state plasma concentration as a basis for a neuroprotection trial. Unfortunately, we were unable to get this funded. However, in South Korea, this trial protocol was published, dexmedetomidine, neuroprotection and pediatric cardiac surgery. The study protocol, presumably enrollment has started. Their primary outcome in these infants under 12 months with 2 ventricle repairs is the proportion of children with a score less than 85 in any of the cognitive, language, and motor domains of the Bayley-3 test and others. I think, unfortunately, from my review, there are some weaknesses in this trial design. The first thing is that the dexmedetomidine stops at the end of anesthesia and not further on into the ICU. The second, there's no imaging test. The follow-up is at 12 months for the Bayley scales, which can be a little bit early. Nonetheless, it will be interesting to see the results of this study. Lastly, I want to mention nitric oxide. So this is a rodent, it's a rat study of nitric oxide in the bypass oxygenator for cerebral protection during selective cerebral perfusion. And the theory is that nitric oxide will improve cerebrovascular blood flow, attenuate ischemia reperfusion injury, improve neuroinflammation, and reduce neuronal death. In this paper, this is a staining for neuroapoptosis with caspase-3, and there's about a 20% reduction. They had a 20 to 60% reduction in other histologic markers of neuronal injury and death. So this agent, I think, has promise. Many of you would have seen this 2022 publication of the nitric study group from Australia and New Zealand of over 1,300 infants and young children receiving nitric oxide versus placebo and the bypass oxygenator with ventilator-free days as the primary outcome. As you can see, there is no difference whatsoever in that outcome. However, there were no neurological outcomes reported. I feel that this agent should be studied. It has promise, and this trial did prove the concept that a large nitric oxide trial can be conducted. So to conclude, allopurinol demonstrated promise in an early neuroprotection study for HLHS and is now being studied in a well-designed RCT in additional cardiac lesions. EPO demonstrated great promise with a strong physiological basis and excellent animal data. However, a large RCT in neonatal HIE demonstrated no improvement with a higher incidence of adverse events. Dexmedetomidine is a promising agent. There is an RCT underway with some limitations to trial design, but its use is already nearly ubiquitous in congenital cardiac surgery, precluding further trials. And then finally, inhaled nitric oxide has some promise in preclinical animal studies and deserves further evaluation for human neuroprotection in congenital heart surgery. I want to thank you for your attention, and I'd be happy to take questions and look forward to the later discussion.
Excellent talk, Dr. Andropoulos. I'm sure that there will be plenty of questions in the chat bar, not only currently, but perhaps in the later Q&A. One that, well, a couple that sort of came to mind. in your assessment, as certainly a thought leader in this field, do you think that there are any, after having reviewed a lot of the potential drugs, do you think that there are any future targets or future drugs in the pipe that that may be coming our way in future trials?
It's a great question. First of all, I would like to thank the organizers, Drs. Bouzid, Juanita, Mavroudis, and Dr. Cervenka for the invitation to the seminar. Excellent. I've learned a lot already. As to drugs in the pipeline, I didn't do an extensive review of that subject for this particular talk. I wanted to focus on drugs that we could really use, today if we had good data. So I'm not aware of anything that's close to what we would consider clinical trials. Question is asked about steroids, also an old drug. So the recent stress trial was published and didn't really measure neurodevelopmental outcomes or neurologic injury. So I don't think there's anything close to being a pharmacologic agent that we're going to be able to use in the coming few years.
Thank you. I apologize for putting you on the spot there, but
no problem.
But I'll do so again. You mentioned that there were you mentioned several of the limitations to having the kind of strength of data that are required to have a nice multi-center trial with such heterogeneity of anesthetic methods, post-operative care, intraoperative variables. If you could just opine a little bit on what you would think could be the most optimal set of circumstances certainly in the United States to have the kind of rigorous randomized controlled trial that could help figure out what would be the best kind of neurotherapeutic in our field.
Yeah, thank you. I focused recently a lot on the anesthetics. There is data from our center, from CHOP as well, that an increasing exposure of volatile anesthetic gases is associated with lower neurodevelopmental outcome scores after trying to adjust for all the confounding variables. So I really was very interested in pursuing the dexmedetomidine. We did try to get this funded through the Pediatric Heart Network, a randomized controlled multi-centered trial of 15 centers. I think you need a network. I think you need multiple centers for adequate numbers. We focused on MRI outcomes as an early marker of differences or brain injury. I think that is optimal, so you can get an early outcome and not have to wait for 2 or 3 years for the neurodevelopmental outcome. So I would think multi-centered network type studies. In the case of dexmedetomidine, in the Pediatric Heart Network in the US, more than 90% of the patients were receiving dexmedetomidine, and the equipoise was difficult. So I think an agent that there is equipoise for, so the allopurinol trial, that's a model, I think, that equipoise, I think, exists for that agent. Nitric oxide would be another one where the uses are not ubiquitous. So I would think those would be the conditions I would think about, for excellent data for pharmacological neuroprotection trials, but look to the crucial trial of allopurinol as a real model.
Thank you again for an outstanding review and sort of the gold standard assessment of what we can all hope to look forward to as we move forward with neuroprotective agents. So with that, we will move to our next talk.
Okay, the next talk will be about intraoperative neuromonitoring techniques presented by Rosemberg, Albores, Figueroa from Monterrey, Mexico. Mr. Rosemberg.
Hi, good morning. I'm Rosemberg Albores. I am pediatric cardiovascular anesthesiologist from Monterrey, Mexico. I thank the organizing committee for this distinction. I will present the topic intraoperative neuromonitoring techniques. I have no conflicts of interest for the development of this lecture. These are the goals of the talk. In recent years, there has been great progress in the surgical results of children with congenital heart disease. This is due to both technological advances and knowledge of pathophysiology that have conditioned a better prognosis. Currently, the improvement in mortality has turned towards morbidity. However, neurological complications in cardiac surgery occur in approximately 6% of patients, with a very large spectrum in which it is difficult to quantify precisely. They are described as the second cause of morbidity associated with cardiac surgery in all ages. In adults, cognitive impairment can occur in up to 50% of patients undergoing coronary revascularization. In children, this is not routinely measured, and in neonates, it is practically impossible to determine the incidence and severity associated with the perioperative period, highlighting cerebral ischemia and decreased cerebral oxygen saturation as the main causes. The perioperative management of children with congenital heart disease has been improved to the current state since the decades prior to 2000. Predictably, life expectancy has increased, and with it the possibility of performing surgeries in increasingly complex patients. Despite these remarkable improvements, survivors of complex cardiac surgeries are at risk for a characteristic set of neurodevelopmental deficits that include poor impulse control, attention deficits, hyperactivity, poor language, cognitive deficits, and limited executive functioning. Despite the vast literature on the neurodevelopment of children with congenital heart disease, there are very few studies that translate these findings of neurocognitive function into adulthood. Evidence in the general adult population suggests that chronic cardiovascular disease leads to cerebrovascular injury and dementia. A paradigm shift is needed to realize these emerging observations. This figure proposes a model that sequentially links congenital heart disease-related cardiovascular disease throughout life with abnormalities in the perinatal, infant, and adult brain. As life expectancy increases, the window of opportunity for repeat injuries continues to lengthen. Why do we monitor the brain? The use of extracorporeal circulation can trigger systemic inflammatory response syndrome, non-endothelial surface-associated immune response, mechanical stress, and surgical trauma. The lack of standardization and formation of interinstitutional care protocols during extracorporeal circulation, albeit in many hospitals in our environment, condition the existence of factors that have an impact on cerebral perfusion. Therefore, understanding the consequences of altering a simple aspect of care during extracorporeal circulation is unclear, and demonstrating the optimal combination of these parameters is prohibitively difficult. Monitoring the brain allows us to establish the basal functional integrity of the patient, detect whether the 7 major adverse events have an impact on the prognosis, identify the impact on of the underlying pathology, make timely interventions, and establish a risk of subsequent disability. Multimodal neuromonitoring has been shown to be safe and cost-effective. There are several options for performing intraoperative neuromonitoring: NIRS, transcranial Doppler, electroencephalography, jugular bulb saturation, evoked potentials, microdialysis, and brain ultrasound. Some more invasive than others, and some with more evidence than the rest. Electroencephalography provides us with diverse information from various measurement points. Monitoring of bifrontal electroencephalography waves detects neocortical synaptic activity. This pattern is influenced by temperature, alertness, anesthetics, and age. Despite suffering from electrical interference and that its interpretation is operator dependent, some algorithms can be applied to reduce the complexity in its interpretation. The ideal configuration is 16 channels. However, the size of the patient's head is a limitation. By monitoring cerebral silence, it is able to reduce extracorporeal circulation times and ensures a B hemispheric balance when using retrograde cerebral perfusion. The spectral plot represents a single segment of non-stationary electroencephalography data, and the overlay windows are displayed as a spectrogram, which is a trend of electroencephalography activity over time displayed on the two-dimensional plot. It is practical and informative to easily observe a change in the electroencephalography at the time of a specific anesthetic dosage, collect the specific drug signature, and a balance of analgesia and arousal stimuli. It also quantifies cortical activity through a spatial incoherence presented by a probabilistic relationship with the depth of anesthesia and sedation. It is a predictor of cognitive deterioration and reduce the risk of postoperative delirium. Combined with the NIRS, it helps to detect cerebral ischemia during pediatric cardiac surgery, facilitating anesthetic dosage and reducing hemodynamic alterations. NIRS is the most frequently used technique, and together with jugular venous oxygen saturation, represents regional and global cerebral oxygenation. They are highly correlated and describe the relationship between cerebral oxygen metabolic rate and cerebral oxygen delivery. NIRS has the advantage of being non-invasive in real time and does not require pulsatility. Their position must be taken care of and is always recommended using two sites, cerebral and somatic, to be compared between them. During selective cerebral perfusion, two cerebral and at least one somatic should be used. The somatic cerebral index of variation must be measured than 10%. This linear dual monitoring system allows us to detect early changes in systemic perfusion while cerebral perfusion is maintained. There are individual variations in the baseline measurement. In premature patients, the baseline measurement is between 55 and 85, while in a cyanotic congenital heart disease, it can range from 46%. This is confirmed by studies by Court and Fenton that show significant lower measurements in shunts from left to right. There are also differences in the various monitors that exist from the measurement algorithm, the way to calibrate, the proofs, and their adaptation to the geometry of the head. Values minus than 50% are associated with a higher risk of cognitive impairment, frontal lobe damage, heart attack, prolonged mechanical ventilation, and hospital stay. The 20% decrease in the baseline is relevant considering the time that say decrease lasts. This is one of many studies where a positive correlation has been described between cerebral oxygen saturation, lactate measure 24 hours after surgery, and the probability of death and neurological deterioration. Evidence of negative correlation between lactate measurements and regional cerebral and somatic oxygen saturation at 4 postoperative hours described by Ormesi. Likewise, Dent describes the appearance of new cerebral ischemic lesions related to cerebral oxygen saturation greater than 180 minutes in hypoplastic left ventricle syndrome. Owens demonstrates the increase in creatinine levels and the risk of renal injury related to renal saturations less than 50%. The combination of electroencephalography, processed electroencephalography, and NIRS is capable of identifying 90% of neurological alterations in the intraoperative period, while the remaining 10% is identifiable by transcranial Doppler, which shows a correlation between cerebral blood flow and velocities in the main arteries. It has a precise indication during selective cerebral perfusion, and high flows correlate with apparition of delirium. This is a summary of the monitors described. And in conclusions, there is sufficient evidence to consider that neuromonitoring in pediatric cardiac surgery is useful and mandatory. When using these monitors, it is important to consider baseline measurements and trends during the procedure. They must always be compared on themselves, and the sum of the parameters will provide us with more information than by themselves. As a predictor, it has limitations, but when analyzing all the complete parameters, it is capable of suggesting potential damage associated with cardiac surgery and has a real impact on the general prognosis. Thank you.
Thank you very much for that excellent review of kind of our limited but certainly somewhat effective ways of providing neuromonitoring in the operating room. You had mentioned a little bit about the cost effectiveness of these various strategies. I was hoping you could comment a little bit further on that, because it seems like a lot of groups are using these. Some of them are using multimodal, some of them are using single modalities, and certainly some of them are a lot more cost and labor intensive than others. So I'm wondering, just to put you on the spot a little bit, if there are any data about cost efficacy. I know there are in the adult literature, but if you could comment on that, I think that would be great.
Yes, I think it's cheaper than we can use some of these issues. For example, it's cheaper detect some the saturation in nears and correlated with electroencephalography, processed electroencephalography, than don't have any of these issues, and we can have a potential complication, a neurological complication in our patients. It is cheaper that we can do any think about optimize at the moment of the saturation, for example, that we can't optimize the patient, for example, 24 hours after that the lesion can't produces.
Excellent. There's a question in the chat box that's of a similar vein. The question is, for limited resource centers, what would you say would be the best monitoring strategy in terms of efficacy and its relationship to limited resources?
Okay, at least NIRS, because, for example, two proofs, one cerebral and one somatic, because the difference and correlation between is so important.
Excellent. And as a reminder to those tuning in, we should have time at the end for a general Q&A session. So please keep those questions coming in the chat box, and hopefully our next couple of talks will spur additional discussion. So with that, we will move to our final lecture.
Our final lecture will be by our co-chair, Constantine Mavroudis from Philadelphia, USA, Innovation in Neurodiagnostics and Neurotherapeutics and Congenital Heart Surgery. The floor is yours, Constantine.
Good morning. I would like to thank the organizing committee for the opportunity to present this and for their continued outstanding efforts to give this high quality educational content to the global community. I'm going to be talking today about the future of neurodiagnostics and neurotherapeutics in pediatric cardiac surgery. Many of these will be some of the things that our group is working on, and some of them will be highlighting works of other groups. There's quite a bit to get through. This is by no means an exhaustive assessment of the current research that's going on, but these are things that I feel will play a major role in the next generation of neurological protection and therapeutics in our field. And I have no financial disclosures. The purpose here is to become familiar with novel neuroimaging and neurotherapeutics that are being developed, as well as to get a brief understanding as to what's going on with mitochondrial-based diagnostics and therapeutics. So this is a slide that unfortunately we're all too familiar with. The most critically ill patients in the hospital who have maximal amount of monitoring and therapeutics throughout basically every organ system in the body, but they have no high fidelity way of assessing the ongoing neurological functions. You'll see here this child clearly has nothing on the head, and even if they did, it wouldn't really wouldn't tell us exactly how the brain is doing in this critically ill period of time. As other speakers will no doubt have presented earlier today, there are major problems with neuromonitoring techniques in our field. The fact that neuro outcomes have not gotten any better in cardiac surgery in the last 30 to 40 years. There's an increased recognition of long-term disability, which takes many forms and is a major source of comorbidity and societal expense. And this is present in multiple papers. There are many reasons for this, which has also been discovered or discussed in this section. I won't try to recapitulate such a wealth of things in this topic, but there are many reasons for this. And overall, I would argue that our knowledge of the pathophysiology and therefore our therapeutic window and the markers for appropriate therapy are incompletely understood. And this is also made worse by the fact that we still don't understand how cardiopulmonary bypass affects, autoregulation and how that specifically can be manifested in the brain, and how we can better target perfusion at the brain level in order to maximize cerebral demand or maximize supply while addressing any issues with over demand during cardiac surgery. The things that we can try to control with this are things like neuromonitoring, but unfortunately, there really haven't been too many improvements in neurodevelopmental outcomes with these advancements in neuromonitoring. We've tried things like earlier surgery, continuous brain perfusion, shorter operations. We've tried goal-directed care and improved diagnostics, and a lot of these have fallen short. And I think the reason why a lot of these things have fallen short is because we really don't have better neuromonitoring devices and therapeutics to help understand and guide intervention that could help prevent primary and secondary neurological dysfunction in cardiac surgery. In an ideal world, such neuromonitoring would be high fidelity, it would be continuous. It would assess cellular demand, not just the period of time after cells have died, which is of course too late to have any meaningful intervention. And this would of course be non-invasive. But unfortunately, our current world, the high fidelity and sort of gold standard ways of assessing things like cerebral oxygen demand and oxygen metabolism are things that are invasive, which of course is not practical for most surgical patients. Additionally, they don't really have intervention thresholds by which to guide therapy, particularly during heart surgery. And there's, of course, a risk of primary and secondary brain injury with the placement of these invasive probes. The extant non-invasive technologies, which have been reviewed in this session, they lack interventional thresholds as well. They're both imprecise and they lack spatial resolution and accuracy, which is a major issue in trying to both diagnose and treat brain injury. And our best neurodiagnostics are really just a snapshot that really detect pathology way too late to really make any meaningful efforts toward prevention or therapeutics. So we'll talk first about the innovations in neuromonitoring. These are things that are very near and dear to myself and my colleagues, things like advanced optical monitoring to get things like ICP, cerebral blood flow, cerebral metabolic rate, and tissue saturation. And then we'll talk a little bit about mitochondrial monitoring and contrast-enhanced ultrasound. The details and the science behind the advances in optical imaging are kind of beyond the scope of this talk, but it is a different way of leveraging NIRS-based technology in order to get absolute concentrations of oxy and deoxyhemoglobin as opposed to the current trend monitors that we have. And if you leverage that technology with a different type of optical spectroscopy as well, you can get things like cerebral blood flow by measuring the microscopic movement of red blood cells through the microvasculature. And you can take all of this and you could get from the blood flow and saturation levels, you can get cerebral metabolic rate with this non-invasive technology. You can also leverage these different wavelengths in order to look at things like cytochrome C oxidase and looking at the intracellular water components and the extracellular water components to get things like ICP. So again, science is a little bit beyond what we have time for. I'm happy to address any of these things in Q&A, but Many of these things have been validated in both animal and human models, but we'll just recapitulate a little bit here on what our group has done with looking at cerebral blood flow and as well as cerebral metabolic rate. As you can see here, they're highly correlative. These are this is in pigs, and it was published in journals Cerebral Blood Flow and Metabolism. We also did this looking at cerebral microdialysis and looked at and said that there was a pretty positive correlation between oxygen extraction, which is a non-invasive way of measuring cerebral metabolism, and things like lactate pyruvate ratio and glycerol, which are invasive markers of cellular stress and bioenergetic failure in the brain. And this was published in 2022. We did something similar with ICP, as you can see here, highly correlative as well, looking at just a different way of leveraging this novel technology to look at extracellular water and pressure levels. And as you can see here, they are correlative. So this type of technology is definitely going to be coming down the pike soon. And may have a significant effect on neuromonitoring. When we're talking about mitochondria, to shift gears here a little bit, I would argue, and our group would argue, that this is really the fulcrum beyond which the cell makes the critical decision either to survive or to die from an insult. And as this schematic can demonstrate, one, I'd just like to highlight that cytochrome C is here in the electron transport chain, and I'd also like to highlight that this is sort of a vicious cycle of mitochondrial dysfunction leading to ultimately cellular death. If we can monitor cells to get to this point, and if we can intervene before this becomes irreversible, I would argue that this is truly the final frontier of diagnosing, preventing, and treating neurological injury in our patients. What we've demonstrated so far is that even cardiopulmonary bypass results in decreased cerebral metabolic function in the immediate postoperative period. We've also demonstrated that it increases reactive oxidative species generation. This is a bad thing and can lead to cellular death, and that deep hypothermic circulatory arrest does make this worse. We've also demonstrated that cardiac arrest results in similar findings, that is to say, worsened cerebral mitochondrial function and increased reactive oxidative species generations. We've demonstrated this as well in traumatic brain injury. And so the question of kind of so what is certainly there, like just because we've demonstrated a phenomenon, what does that actually mean? This study we put out several years ago now, demonstrating that the extent of the mitochondrial dysfunction correlated with cerebral performance categories, that is to say a clinical marker of the extent of neurological injury in pigs. So there is a clinical correlation, and so this stuff does matter. So now the question is, can we monitor these mitochondria? The long and short of it is yes. With similar NIRS-based technology, we can look at the oxidative and reductive state of cytochrome C oxidase. And this has already been used in humans to look at the severity of neurological injury and hypoxic ischemic encephalopathy. Now, what our group did is we looked at a known mitochondrial poison, carbon monoxide, and we exposed these animals to it, and we noticed that you could clearly demonstrate that the cytochrome C functional levels decreased after exposure to carbon monoxide. So exciting potential way of monitoring ongoing mitochondrial injury in the brain. Contrast-enhanced ultrasound is a technology that is currently being used in other parts of medicine, but has not yet reached prime time in cardiac surgery, but I would argue that it very much is about to become. It is a way of leveraging high-fidelity ultrasound and using microbubbles, which are what they sound like, but they are non-toxic, they're incredibly small, and what they can do is they can provide you with fabulous images and continuous understanding as to where the blood is going into the brain, and this is all non-invasive. Now we'll talk about neurotherapeutics, just to try to get through this as quickly as possible. There are certain things that are reaching prime time, or things like noble gases for ischemia-reperfusion injury, microbubbles as therapeutics and delivery platforms, stem cell delivery, and mitochondrial-based diagnostics and therapeutics. So when you're talking about noble gases, you're really talking about xenon and argon. They're inert gases. Their mechanism is incompletely understood, and it's probably different, but there have been demonstrated efficacy in both traumatic brain injury, cardiac arrest, and cardiopulmonary bypass models of injury. This is a preclinical meta-analysis that demonstrated a significant effect size for both argon and xenon in models of TBI, cardiac arrest and bypass and stroke. But the ongoing questions with this, of course, are things like dosage, mechanism, safety, and delivery, all of which will likely be looked at with much more rigor in the years to come. Similar to its ability as a diagnostics, contrast-enhanced ultrasound can actually be used for a therapeutic delivery device in that you could load microbubbles with a drug of interest, be it a noble gas, be it nitric oxide, or be it something else. And you can pop those bubbles using ultrasound at the carotid artery. So this will vastly improve the distribution of the drug to an organ of interest, in our case, the brain. So this is technology that is currently being developed and actually currently being used in preclinical models. And these are just some of the ideas that this exciting technology could bring. Mesenchymal stem cells have been a sort of a hot topic for a long time. A lot of debate behind sort of how they work, what they do, how we can best leverage this. But they are in use in multiple disease states. There can be issues, of course, whether or not the cells actually proliferate on their own or if they stimulate other cells to proliferate. There's also the issue of graft versus host disease, incomplete cellular delivery, and the overall efficacy. So what our colleagues at Children's National did, they put forth a phase 1 trial for mesenchymal stromal stem cells through cardiopulmonary bypass. So what this means is that they've overcome the limitations of IV delivery of stem cells by putting it into the aortic cannula for various patients under 3 months of age, and their findings are ongoing. But look for this. This will be a major contribution when it comes forth. Getting back to the mitochondria as we're wrapping things up, the question, of course, is can you treat the mitochondria? Because why do you care if you can monitor something if you can't treat them? And the short answer is yes, you can. We have used proprietary molecules, things like CMX 2043, and a few other things like, a few other molecules as well that have been used as intermitochondrial membrane stabilizers, which prevent downstream mitochondrial dysfunction, reactive oxidative species, and cell death. And what we've done is we've done this in a traumatic brain injury model, and we've noticed and we've demonstrated that it is significantly better than placebo in stabilizing mitochondrial function and decreasing reactive oxidative species generation. So, but then of course the question is, does it actually work? Just because you treat the mitochondria, does this actually help the brain, and does it manifest radiographically? And the answer to that is yes. We have looked at this in MRIs and MRAs, and we have demonstrated that this does actually help these animals after they have been hit with a controlled cortical injury or a CCI or a TBI. So in summary, that was a whirlwind trip down these innovative devices and therapeutics that are in development to address this major problem that persists in pediatric cardiac surgery. We and other groups are leveraging many solutions from other disease states, things like cardiac arrest, ischemia reperfusion in various other ways, and stroke. And so by doing this, we're hopefully elucidating the pathophysiology and the treatment window of these mechanisms. So I'll just close by saying that this is a highly collaborative study, and as we can all attest as investigators in this space, these are major things and require a lot of resources and a lot of people, way too many people for me to acknowledge in this talk. But this is sort of the future of this research, and I'm very excited to be able to share this with you. Thank you.
I'm now in the somewhat awkward position of having to moderate a Q&A session for myself. So I do see that there is a question in the chat box concerning artificial intelligence applications for monitoring and managing cardiopulmonary bypass to prevent neurological injuries. And the short answer to that is absolutely. What I think the leveraging things like machine learning and artificial intelligence will be very important, but that is also limited by our ability to have neuromonitoring that makes sense. Because if you can imagine having maybe artificial intelligence as part of your team, apologies, that is my daughter expressing her opinion on the matter. If you have AI-based technology that is allowing sort of a smart perfusion platform, it won't really help you unless we have high fidelity markers of just how well the brain or any organ of interest is being perfused. So, you can imagine a sort of sci-fi world where we have the power to direct blood wherever we want it to go. And that could likely be helped out by artificial intelligence. But again, artificial intelligence that's not fed high fidelity data is not going to help you. So that is just one of the more obvious ways I think that artificial intelligence or machine learning could help us in the field of like the future of smart perfusion. But at this point, we're kind of hamstrung by the fact that we can't provide the amount of high fidelity data that would result in meaningful or sensical application of that technology for smart perfusion.
Constantine, that was an excellent presentation. I would like to ask you a question, getting all the data and of all the really make an impact in terms of changes in these patients. I mean, there's a very wide scenario in techniques, places, surgeons, pathology. Where do you think is going to be the real important that we can change this in the future, perhaps?
Yeah, that's a great question. I think that I may be overly optimistic about the speed with which certain things can be adopted, but I do think that the era of mitochondrial diagnostics and therapeutics is going to be a major change, not just in neuroprotection for congenital heart disease, which we all think is important, but really in the management of any shock-related disease. I mean, this has been touched on briefly in one of the lectures earlier today concerning just sort of the pathophysiologic differences between what we're all talking about, which is neuroprotection, in some ways ischemia reperfusion injury, in some way managing cellular dysfunction and pathology. But what this all comes down to is that we're putting these patients in some degree of shock, and our ability to treat it is very much limited by our ability to diagnose a problem before it becomes an issue. The analogy that I like to use is, thinking about the mitochondria, not just as, the powerhouse of the cell, which we all learned in middle school, but to think of it as a nuclear power plant, and that, at a certain point, that power plant can melt down. And if you can diagnose that problem before, and you can intervene before that happens, all of a sudden you start saving cells en masse. And then your problems of downstream neurologic injury in a response to either an extrinsic or an intrinsic pathophysiologic process, that is to say, either the ischemic hit or the reperfusion hit, or the different types of pathology to which neurons in particular, and every cell in the body more broadly, is exposed in periods of shock. So I think that this technology represents an amazing breakthrough that, if properly leveraged and if properly vetted prior to widespread clinical application, could have wide-ranging and pretty profound impacts on the way that we treat shock, the way that we think about complex pathophysiologic processes, and ultimately how we diagnose and treat brain injury for children.
Okay, that's great.
Constantine, may I ask a question, please?
Please.
Is there any development in nanotechnologies used in nano sensors for hemodynamics, for example? Is there any development in this area of technology?
Yeah, so that's a great question. It's one that I will do my best to address, but this is the limitations of just what I know and what I'm aware of that's going on. This is not something that I have a whole lot of expertise in, but what I do know is happening is nanotechnology as a platform for both conformational change, biocompatibility, as well as drug delivery are certainly things that are ongoing. So things like microscopically deformable substances and sort of materials that could potentially have a semi-contractile nature, not necessarily as a replacement for myocytes, but for things like a quasi-pulsatile Fontan circuit have been proposed. Improved biocompatibility of perfusion circuitry has been proposed, with leveraging things like nanotechnology to create a smarter way of coding our circuitry, more biocompatible, with all the potential benefits associated therewith. And I'm sure there are many examples of nanotechnology being used in the therapeutic delivery space. I'm just not aware of those. The things that I'm aware of are the things that I'm either casually interested in or that I know are happening either at our institution or somewhere else.
Thanks very much.
Constantine.
Please.
Can we ask Dr. Jonas to give his opinion? And I mean, there are some centers that propose circulatory arrest strategies. There are some centers that propose regional severe perfusion strategies. There's data from patients that have genetic and social issues from when they're born. What would be a take-home message, like to summarize all the information that we received today in the lectures? If Dr. Jonas can make some thoughts on this, given his experience and all his research in this topic.
Oh, thanks, Ignacio. That's very kind of you. I think we've heard a lot of wonderful information today. There are really no clear answers to a lot of questions, as I pointed out in my presentation. And I think there are a lot of wonderful research opportunities to answer many of the questions. I think there'll be more questions raised than answers provided. I do think that we should feel proud as a specialty of the improvements that have occurred in the area of avoiding major brain injury. There's been a lot of focus today on the subtleties of neurocognitive outcomes. And I think when we look at studies that suggest, well, we're not actually making that much improvement, really what we're doing is starting to look at all the other sources of neurocognitive problems in children with congenital heart disease. And I don't think that should allow us to take our eyes off the fact that improvements in the operating room have made a very dramatic difference to kids in cardiac surgery. On the other hand, there are still cases of major brain injury, and those of us, many of us, are called on regularly by lawyers to give our opinions on children who have suffered major brain injury. And I think it would be interesting to look at the financial settlement, certainly in the United States, for children with major brain injury during cardiac surgery. It tends to be not something that people talk about. There hasn't been any discussion of it to date, but I can assure you that it still happens. For example, I'm aware of several cases I've been asked to comment on where during reoperative surgery, the atrium has been adherent to the sternum. The patient's been on femoral bypass. Because the patient has a stage 2 single ventricle type physiology, their right atrium is actually the left atrium. Air has been entrained into the beating heart, and air has been pumped to the brain, and the patient has been either brain dead or close to it because of massive air embolism. And there are situations of arterial dissection, for example, aortic cannulation causing major brain injury. So there are a number of areas where patients are still suffering from major brain injury that really need to be discussed. But the answer to the question of should we be using circulatory arrest, regional perfusion, adjunctive methods, I think we don't have a clear answer to those questions. Certainly in my own practice, I have to say, I continue to use hypothermic circulatory rest, but in a hopefully more intelligent fashion based on the many studies that have been reviewed. And it's not a binary decision. It's not, are we going to do this with circulatory rest? Are we going to do it with continuous bypass? Are we going to use some form of adjunctive perfusion? It's possible to do one component of an operation with circulatory arrest and say limit that duration of circulatory arrest to say 15 or 20 minutes. And then to do other components of the operation that can be done either with selective cannulation of a head vessel or just aortic cannulation and using a lower flow rate and using near-infrared monitoring, as was pointed out, to maintain, to be reassured that you're maintaining cerebral oxygen status. So lots of great questions raised by today's presentations, and the issue of avoiding major brain injury is something that all of us still need to think about. Thank you.
Great.
Excellent summary. I believe Dr. Andropoulos has raised his hand. Dr. Andropoulos.
Thank you. I just had a couple of comments. This has been an outstanding seminar. I wanted to push back a little bit on the flying blind today concept and NIRS. I think near infrared spectroscopy, the Boston group and our group has demonstrated that low NIRS in the perioperative period is associated with later neurodevelopmental outcome problems. And while we don't see a controlled trial, if you will, I think it has become standard, and there is certainly physiologic reason to improve cerebral oxygenation. And I completely agree with Dr. Jonas that I think you can probably avoid most catastrophes, or at least have early warning with NIRS. We have a case report from 2006 about a cannula malposition case report. That's one example. I could not agree more that we need more advanced neuromonitoring, and it's exciting to see what is coming down the road. The basic NIRS technology that we use in the OR today hasn't changed much in more than 30 years. And just a comment about regional cerebral perfusion. We did publish, this is now 20 years ago, it's hard to believe, but we did a careful study of regional cerebral perfusion using transcranial Doppler and NIRS and measuring blood flow in the middle cerebral artery of both sides of the brain and NIRS, and showed that if you use transcranial Doppler to help guide flow rate on NIRS, you can get good, if you will, blood flow and oxygenation to the contralateral cerebral hemisphere. The MRI changes were no different with NIRS, and then the comparison group without NIRS, and the neurodevelopmental outcome later at 12 to 36 months was comparable to full flow bypass. So I think for regional cerebral perfusion in particular, the devil is in the details, and we continue to use transcranial Doppler to this day to help adjust blood flow. And that's all I have to say. Thank you again for inviting me to speak at this great conference.
It's an excellent comment, and I certainly appreciate that. And I didn't mean to poke the bear on this one, but and we are in our institution using NIRS as well, with the important provisos that the algorithms are proprietary. These are all assumptions that this technology makes, which of course, when pushed to extremes, can be quite variable and difficult to interpret. But yeah, I mean, I guess the point that I was trying to make in that talk is not necessarily that we're flying blind, but that our instruments are not exactly precise. So, while that was kind of a stark image, in reality, there are things that we do put on the head in these situations. But, I would argue that without definitive thresholds for intervention, and without a true, perhaps non-realistic burden of proof, but without any kind of real veracity for any temporary or even long-term deviation of those values. It's really hard to know what to make of them. I mean, I fully agree with you. We use it for all of our patients because we've all had cannulation disasters where, you know, if they weren't there, we wouldn't have known, the patient would have been brain dead. And we certainly react to those in the ICU, but I think most of us would agree that we don't exactly know when we should start getting worried, what changes are really deleterious, and what the kind of absolute indications for intervention and how to monitor and how to track those interventions would go with our current NIRS-based technology. So thank you for that. I think at this point we can probably open it up for general discussion if anybody has any additional questions for any of the speakers. There was a question concerning by Dr. Becker concerning the early institution of rehab and whether or not that may have improvement in status after cardiac surgery. It's certainly not something that I have a whole lot of experience with, but I'm wondering if any of the other panelists or speakers have had experience with a protocolized assessment of, or a protocolized program on early rehabilitation in certain patients after either presumed or actual neurological injury.
Yeah, I can comment quickly. As in many programs now have a standard for neonatal cardiac surgery, a standard follow-up in the neurodevelopmental clinic. And we don't have a controlled trial, if you will, but I think it's standard care throughout pediatrics to evaluate these patients. And we certainly, starting at 3 months, they'll come back to the clinic. And if there are worrying signs, they will be referred to early childhood intervention. So it is standard. I mean, ideally in our system, every patient comes back for neurodevelopmental outcomes. We do actually do clinical MRIs routinely. And if there are concerning signs, there is early intervention. I'm not aware of controlled trials, but that is a great idea that certainly has every reason for us to believe that it would be very helpful.
And we have a few more questions or a few more minutes if people would like to take this opportunity to ask questions of this group. As a reminder, you can use the chat feature or you can simply raise your hand and we'll call on you.
Constantine? Constantine? It's Abdel Malik.
Yes, thank you.
May I ask a question to Dr. Jonas?
Please.
In our countries, limited resources countries, we have not the ability to take care of these congenital patients everywhere. So the neurodevelopmental problems in patients operated very late, is it the same or not? And if it is not the same, what you have to do to reduce this impact?
Yeah, that's an important question. Actually, studies go way back that have documented that a long delay before undertaking corrective surgery will certainly impact neurocognitive outcomes. Dr. Neuberger published a paper back in the 1980s or 1970s, perhaps, that demonstrated that long-standing cyanosis in kids with transposition who weren't operated on for several years was associated with worse neurocognitive outcomes. So the key really is to try to find these kids at an early age and to perform surgery to correct their problem, ideally a total repair. But if that's not available because you don't have open heart surgery, then at least a shunt to avoid chronic cyanosis would make some impact on neurocognitive outcomes. it's really the whole point and mission of the World Society to try to improve access to surgical care and to reparative procedures for kids with congenital heart disease. So it's something that all of us need to address for sure.
Thanks.
All right, well, if there are no additional questions for this panel, we will give you a few minutes of your week back. I just want to, on behalf of everyone, thank everyone for their participation and to the speakers for their outstanding contributions. And with that, we will conclude things.
I want to thank all our esteemed colleagues for sharing their expertise with us today, and to all of you for joining us. This has been the 27th in our series of monthly webinars in congenital heart surgery from the World University. We would like to invite you to join us for our next webinar on clinical care for pediatric and congenital heart surgery. It's going to be held on May the 20th at 9 a.m. Montreal time. I want to remind everyone as well that this webinar was recorded and will be available on the World University for Pediatric and Congenital Heart Surgery website in the coming weeks. Thank you and have a great weekend.